to all those who are again in the meeting room for us. Thank you. I see new attendees, new people are joining. Let us give a few minutes to all of them. All right. Welcome. Okay, let me try and practice your names first. In case I'm pronouncing your name wrong, please let me know. Okay, please correct me right then. It's, I'm sorry, who is Vivo V2029? May I please know your name? And I'm sorry, I'm just asking it in case we might need to know your names or pronounce your names for further interactions, you see. It's Selena Cruz. Oh, wait.
Hi, sorry, I'm not sure if you're asking me a question.
Hi, Selena.
Hi.
Yeah. Am I pronouncing your name right?
Yes, that's how you say it.
I'm glad. Thank you so much for confirming.
Thank you.
Yeah. So where are you from, Selena?
I'm calling in from Denver in Colorado.
That's great, Selena. Thank you so much for joining us today.
Thanks for hosting.
Yeah, we will definitely start in a few minutes. Stay connected. Okay, here is one introduction from Oran. Thank you so much, Oran. I'm glad. And it's one more name, Okocha Onyika James. Okocha, if I'm not wrong. Please correct me if I'm wrong.
It's Okocha Onyika James.
Okay, let me repeat it. Okocha Onika James.
Okocha
Yeah?
Onyika. Onyika.
Okay, Okucha Onika. Is it?
Yes, better.
Thank you so much. Okay. We all know Dr. Sampurnam. She is one of our OCNs and one of my favorite speaker. Yeah. So one of our attendee today is Dr. Sampurnam, and the next one is it's Daoud. Daoud from Nigeria. Is it right? It's Daoud.
Dotson.
Daoud. Is it correct?
Yeah, you tried.
Yeah, thank you so much. So let me announce my name to all those who are new in the meeting room. Dear all, my name is Ghazal Johar, and you can pronounce it as however it is favorable to you. You can call me dear moderator also. So it's Ghazal simply. Please call me Ghazal. And if you want to call me moderator or the host, I'll be glad with that too. Please feel free, be comfortable. Yeah. Okay. Yeah, sure, Selena. It's Ghazal Johar. And I'm from India. All right, let me know all of you. I'm sorry, I didn't ask your country. Can you please write down your name with your country name in the chat box so we will know each other? and I'll know from which country are you all from. I repeat, my name is Ghazal Johar and I'm from India. It's Siri Hoffman from USA. Selena from Denver. Aksha Anika James from Nigeria. Welcome. Okay, with that, let me ask, are we having Dr. Habchi in the meeting room right now? As I can see, Professor Daoud in the meeting room. She's our second speaker today. I'm asking for Dr. Habchi. Dr. Habchi, are you in the meeting room yet? We will start the meeting in next 7 minutes. I mean, the very first talk. I just got 3 answers in the chat box. As I can see, we are having more attendees in the meeting room. Please, everyone, please introduce yourself. Yes, hopefully, yes. The team is working on the live stream right now. And even if not, the whole meeting will be posted on LinkedIn as well, on LinkedIn, on YouTube. So please don't worry. If you are having any further questions, please ask me here. The whole meeting will be available on YouTube and the links will be provided to all the social media platforms. So in case I see so many attendees, they want to share the meetings at their platforms, their personal accounts. Please feel free to do that. I'm asking Dr. Habchi if she can make it in the meeting room. And let me introduce Dr. Habchi also. She is also one of our OCMs. All right. Let me know from which stream are we from? I mean, in which stream are you interested the most? And it's not necessary that you have to answer through chat box only. You can come up on the screens and talk to me. Otherwise, I'll feel like I'm talking to the screen also only. Please do me a favor and come up on your screens, unmute yourself and talk to me, ask me questions and I'll give you the answers, or in case any suggestions, we are ready for it. Please feel free to share your suggestions. Okay, more attendees are joining. Okay. Professor Daoud, can you please do me a favor and ask Dr. Habchi if we can help her in any way? As we all know, she keeps on traveling, and so the internet facilities fluctuate. And thank you in advance. All right. I asked a question to our earlier attendees that please give your full name with your country name in the chat box or share with me here. Please let me know where are you from. It will help me to know you better. So I request to all the new attendees who joined just yet, please share your full name and your country name with me. And if it'll be great if I could just know more about your interests, your field of interest. Okay. So Dotun is a student of physiotherapy. Great. Okay, so the Dotun, can I talk to you? Can you please come up on the screen for once? As we are in a meeting, and this meeting is wholly dedicated to the brain injury topic, right? So how far do you think the physiotherapy is effective in the brain injury treatments? What are your thoughts on it? Our first speaker is here. I'm glad she could make it on time.
Good evening, everybody.
Good evening, Dr. Habchi. How are you?
Fine.
Great, doctor.
How's your day going?
I actually explained in the beginning of the meeting also. So let me explain it. My day was great, and that's why I was asking everyone how their day is going, as the weather here in India is fabulous in these days. What about you?
Fine. I apologize for Professor Bouallag because she doesn't participate today because she is ill.
Oh, we really hope she get well soon. I'm sorry to hear that. And that's fine. I'll talk to Dr. Bouallag later. And yeah, that's fine, as we are having you here. And I'm sure you'll cover up the topics well. And we will definitely meet Dr. Bouallag in the next meeting some other time.
I tried to represent the more interesting case report about traumatic brain injury, array cases.
Wow. So are we excited, everyone?
Okay.
Come on.
And before starting the study of these cases, I wanted to remind you about some head injury and the traumatic brain injury.
Okay.
Okay.
See, Dr. Habchi has so much to discuss, so much to, so many insights to provide today. Yeah,
Okay.
we are excited for it. So it is the time. The screen is all yours, everyone.
Okay.
Our very first speaker, Dr.
So
Nawel
can we
Habchi.
start?
Yeah.
Okay.
All the very best to Dr. Habchi.
We want to share the flyers. Okay.
Perfect.
You see the flyers?
Yes.
Okay. So the title of our conference is Interesting Cases of Traumatic Brain Injury. I will show you two cases. The chronic subdural hematoma developed from an acute subdural hematoma. This is the first case. The second case is about arachnoid cyst associated with intracystic hemorrhage and subdural hematoma in the case of one child. Before starting the study of these two cases, I want to show you or remember what is the head injury. A head injury is any sort of injury to your brain, skull, or your scalp. This is the definition of the head injury. This may range from a mild bump to traumatic brain injury, and the consequences and the treatment depend on the severity of this injury. The common head injury are the fracture, the concussions, the scalp wound, and the skull fracture. This is the common head injury noun. And also, we have the consequences of this head injury is the hemorrhage and hematoma. The most common causes of this head injury include the motor vehicle accidents, the falls, the physical assaults, the sport-related accident. And in the most cases, your skull is protected by your brain from the serious harm, but your spine is not protected. This is why we have the association of the head injury with injury of your spine. The consequences of this head injury are hematoma. Hematoma is a collection or clotting of the blood outside of the blood vessels. This is the definition of hematoma. It is a collection or clotting of the blood outside of your blood vessels. The hemorrhage is uncontrollable bleeding, and we have two cases. When the bleeding is located in the space around your brain, it is called the subarachnoid hemorrhage. And when the bleeding is located in your brain tissue, it is called intracerebral hemorrhage. Also, we have the concussion, the skull fracture, the edema, and also the diffuse axonal injury. In this case, we haven't the hemorrhage. Here, we have damage of the brain cell. It is considered as a shear injury, and we see it in MRI, in the brain MRI, and not in the CT scan. This diffuse axonal injury don't appear in the CT scan, but with the time it's appear in the MRI, the brain MRI. Now we pass to the traumatic brain injury. The traumatic brain injury is considered as insult of your brain, and the origin of this insult is external mechanic forces, and this traumatic brain injury possibly lead to the permanent or temporary impairment of cognitive, physical, psychological function. And in some cases, we have the association of diminished or altered states of your consciousness. This is the definition of traumatic brain injury. It is external forces, external insult of your brain. Look here. If you remind, we have 3 layers, 3 meters. This is the skin. This is the bone. And here we have the dura mater, the arachnoid matter, and pia mater that cover our brain. The arachnoid contain the blood vessel. Between the dura mater and arachnoid, we have this space, subarachnoid space. And here, look, we have the artery. This is the origin of some bleeding. I want to show you these 3 matters in order to know the 2 kinds of hematoma. We have epidural hematoma and subdural hematoma. The synonym of epidural hematoma is extradural hemorrhage. Here, the site of the bleeding is between the dura mater and the bone. However, in the case of subdural hematoma, the bleeding between the arachnoid and dura mater, and the origin is different. Here we have the arterial blood in the case of epidural hematoma. However, in the case of subdural hematoma, we have venous blood. The origin is different. Origin of bleeding and also the site or locations. The most complication of head trauma is intracranial hemorrhage. We have extraaxial hemorrhage, epidural and subdural hematomas. And also we have subarachnoid hemorrhage. As I said before, the subarachnoid hemorrhage is the bleeding which is located in the space around our brain. In the case of intraaxial hemorrhage, here the bleeding is located intraparenchymal or in intraventricular. This is why it is named intraaxial hemorrhage. We are based on the extraaxial hemorrhage, the epidural and subdural hematoma, because in these 2 cases, we do some surgical management. In the case of epidural hematoma, immediate surgical evacuation is the treatment of the choice. And Professor Daoud will explain to you all these details. In the case of subdural hematoma, as I said before, the bleeding is located between the dura mater and subdural. This is the subdural hematoma, and this is the dura mater, and this is the arachnoid mater. And look here, we have this subdural hematoma, which exerts a compression on the brain tissue. And as I said before, the origin of this subdural hematoma is a venous bleeding. According to the time, we classify the subdural hematoma in 3 classes. The first one is the subdural, acute subdural hematoma. In this case, depletes for less than 3 days. The second class is subacute subdural hematoma. Here, the time is between 3 days to 3 weeks. And in the chronic subdural hematoma, here the bleeds exceed 3 weeks, 21 days. This is the classification of subdural hematoma. It is according to the time of the bleeding. Now we pass to the subarachnoid hemorrhage. As I said before, the subarachnoid hemorrhage is located in the space around which is located around the brain. And look here, the difference between CT scan slice of the brain and subarachnoid hemorrhage CT scan slice. And this hemorrhage appear braid weight. This is the space around our brain. And here is the location of the subarachnoid hemorrhage. And in this case, the patient present a severe headache mentioned as a finger's clap headache. It is considered as the worst headache of one life. And this patient vomited also. And he doesn't present a focal neurological deficit. And there is one classification or one scales named has and had, which is used for this classification of subarachnoid hemorrhage. Now we pass to the cases report. The first case report is chronic subdural hematoma, which is developed from an acute subdural hematoma. The chronic subdural hematoma is one of the most frequent pathology treated in the department of neurosurgery. Its pathogenesis and adequate treatment remain poorly known despite actual investigation. The origin of the bleeding is usually a subdural hygroma, but in some cases, in few cases, we have the acute subdural hematomas. We report rare cases of chronic subdural hematoma developed from an acute subdural hematoma treated in our department with a good outcome. It is a patient aged of 73 years with a history of chronic alcoholism and Alzheimer's disease. And he presented to emergency department with headache, which was worsening over the last month before his admission. And in his history, he has had trauma, and our physical examination was unremarkable for a neurological deficit. Look here, we have the history of head trauma. Look here, the brain CT scan show a left hemispheric subdural collection. This is a radiological definition of acute subdural hematoma. It appeared hyperdensive. Our patient underwent conservative treatment at the beginning. This conservative medical treatment is based on corticosteroid and rehydration, and the duration of the conservative treatment is 1 week. After this, after 2 weeks, the patient is readmitted to our department because he represents left unilateral mydriasis and right hemiparesis, and the CT scan shows 13 millimeter thick hypodense left hemispheric subdural hematic collection with a sign of recent bleeding. In the first step, we have, before 2 weeks, we have an acute subdural hematoma of 8 millimeter. And the patient had a conservative medical treatment based on corticosteroid and rehydration and have a good outcome. And after 2 weeks, he was readmitted to the emergency because he represents unilateral mydriasis and rate hemiparesis. And look here, the thickness of the collection with the recent bleeding. In this case, we do emergency surgery was performed and we evacuate this hematoma. And this is through a burr hole. And after 1 month later, the
Please don't worry. There might be some internet or some network issues. Dr. Habchi will be back in a while. Sometimes it happens as we all are from different countries, connecting from different areas. Yeah. Thank you so much, Selena, for letting us know. I'm glad that you are here actively and paying full attention to it. And thanks to Dotun also. Okay, I've got one more name to know how to pronounce it. I'll ask it later. Dr. Habchi is here again. Yeah.
Sorry for this error.
That's okay, Dr. Habchi. We know the internet problems, the network issues, right?
Okay.
Yeah.
Okay.
Please take your time.
This is the contracerebral CT scan after 1 month. Look here, we haven't the hematoma. And here, we have this collection. So, in the discussion of our case report, we want to know what is the origin of this chronic subdural hematoma. In the literature, we found that in few cases, the acute subdural hematoma is the origin of this chronic subdural hematoma. Why this? Because this acute subdural hematoma is absorbed by redistribution of the blood to the other site within a few weeks. However, some cases can become chronic when there is a sufficient potential of subdural space. This is the causes of the emergence of this chronic subdural hematoma from the acute subdural hematoma. So there is other factor according to the literature. This, we have the Korean author named Lee, who analyzed retrospective a series of 177 patients, and he finds that the older age and the large hematoma cysts were associated with the progression of acute subdural hematoma to a symptomatic chronic subdural hematoma. So we can know that the sufficient potential subdural space associated with the older age and the larger size of hematoma led to the transformation of acute subdural hematoma to the chronic subdural hematoma. Also, we want to know the exact cause of our acute subdural hematoma. Here, we want to know why the acute subdural hematoma is transformed to the chronic. And here, we want to know what is the exact cause of acute subdural hematoma. The origin of the bleeding are unclear in our reported case, but it would probably be related to the vascular fragility due to the use of alcoholism and also the age of our patient. And all this is associated to the head injury. So the causes of the emergence of acute subdural hematoma is the fragility of the vessel due to the alcoholism, the old age of the patient, and also the head injury. Also, we find that the transformation of this acute subdural hematoma to the chronic subdural hematoma is probably related to the microvascular proliferation within the hematoma. The development of microvascular proliferation within the clot of acute subdural hematoma can lead to the rapid expansion and its transformation into organized or symptomatic chronic subdural hematoma. So this is the causes of transformation of acute subdural hematoma to the chronic. In our cases, the surgical evacuation and drainage is mandatory, and the surgical evacuation through the enlarged burr hole is considered as appropriate method to evacuate this chronic subdural hematoma. Now we pass to the second cases. Arachnoid cyst with intracystic hemorrhage and subdural hematoma in child. Look here, in the first case, the origin of chronic subdural hematoma is acute subdural hematoma. In this case, the origin of this subdural hematoma is arachnoid cyst. So, what are the arachnoid cysts? The arachnoid cysts are benign congenital intracranial lesions, accounting for about 1% of all intracranial lesions. These lesions are often asymptomatic and have been detected incidentally by MRI or CT scan. However, in some cases, especially in the case of a child, it can be the cause of intracystic hemorrhage and subdural collection or subdural hematoma. And this hemorrhage can cause neurological deficits that require neurosurgical intervention. We report the cases of chronic subdural hematoma secondary to rupture of a symptomatic temporosylvian arachnoid cyst. So the location of this arachnoid cyst is temporosylvian. And the age of our cases is 4 years. We also reviewed some literature article in order to recommend a surgical approach and the outcome of the different surgical approach as reported. Our boy presented in the emergency with 1 month of headache, and he also her mother mentioned that he has head injury. head trauma. And when we do the physical examination, we haven't a neurological deficit, but the headache was worsening over 1 month. The brain CT scan demonstrates a left collection, hemispheric collection. This is the chronic subdural hematoma. And this is the origin of the bleeding. This is, here we have arachnoid cyst, the origin of the bleeding. The patient was indicated for surgical hematoma evacuation through the burr hole and drainage. And during the post-operative period, the patient was good without neurological deficits. For the discussion, I want to know what is the first description of the association of arachnoid cyst with chronic subdural hematoma. The first description was reported by Daoud. And according to the literature, we have two hypotheses that explain the mechanism of association of chronic subdural hematoma and arachnoid cyst. The first hypothesis stipulates that the dural border cells extend from the dura and adhere tightly to the arachnoid membrane and delimiting a potential space or subdural compartment. And this is when we have a minimal trauma, we will have an increase of the bleeding, and we have the weakening of subdural compartment. The weakness of the subdural compartment with a with association of minimal trauma lead to the emergence of this collection. In the second hypothesis, the arachnoid cyst rupture is correlated to the fragility of the vessel, and this vessel is located around the arachnoid cyst wall. So the fragility of this vessel led to the rupture of the cyst, and also we have some abnormal vein bridging in the sylvian fissure. This vein bridging could bleed spontaneously or after a minimal head trauma. So here, the rupture of this arachnoid cyst is correlated to the fragility of vessel and also the vein bridging in the sylvian fissure. This is the origin of the bleeding and the rupture of this arachnoid cyst. In our cases, the patient underwent the evacuation of hematoma through burr hole are the first cases, and we don't do the craniotomy or cisternoperitoneal shunt of the arachnoid cyst. However, in some literature review, they use the craniotomy and cisternoperitoneal shunt in order to prevent the recurrence of the bleeding and also the recurrence of rupture of arachnoid cyst. But there is other author as Faisal, who has reviewed a case series published between 1994 and 2019, which include 79 patients, and more than 89% were in these cases were treated by only burr hole and irrigation and without craniotomy. And this Faisal showed that this technique can give a good outcome. So even if craniotomy or burr hole and drainage are the most frequent surgical technique reported in the literature, however, the irrigation of this chronic hematoma alone, the burr hole was shown to be adequate in the most cases. So this is burr hole is the most technique used in evacuation of this hematoma. But in some cases, when we have a recurrence of this hematoma, we can pass to the craniotomy. And actually, beside the evacuation of chronic subdural hematoma, the endoscopic or microsurgical fenestration of the cyst is recommended in order to prevent the recurrence. At the end of our conference, after the conference of Professor Daoud, I want to show you some techniques, the burr hole and craniotomy. I show you some videos of craniotomy and burr hole because I know that most of you ask the question, what is this craniotomy and what is this burr hole? After the conference of Professor Daoud, I show you some videos. If you have any question, you can ask me in the part of discussion.
So that's how Dr. Habchi explained what happens when an acute subdural hematoma transforms into a chronic one. And the next part also, which was to be from Professor Bouallag, but Dr. Habchi came forward and explained the second part also. And it was about how does an arachnoid cyst in a child become a source of both intrigue and concern. Thanks to Dr. Habchi.
Thank you very much.
Yeah, we already have a question. We got second question also. So the question was from Selena. Selena, if it is fine, yeah, thank you so much for coming up on the screen. I wanted you to come up on the screen and discuss the question with Dr. Habchi.
Sure. Thank you, Dr. Habchi. That was a great presentation. So my question was about the chronic hematomas that you mentioned. And I know you discussed the burr holes for surgery for drainage, but I was wondering if there's an option to put tubes surgically in that space so that the patients wouldn't need consistent surgery over time, or if but having those tubes placement is not possible for this type of blood collection.
Okay, for the craniotomy, it depends on the location of the bleeding of the hematoma.
Mm-hmm.
So we follow the location of the hematoma. If we have a temporal location of acute subdural hematoma, we use the craniotomy. However, so we have two techniques. The burr hole is used for the chronic subdural hematoma, and there is some cases, some neurosurgeon who use one burr hole and other two burr holes. At the future video, I show you the two burr hole. We evacuate the chronic subdural hematoma, and the location of the burr hole depend follow the location of the chronic subdural hematoma. This is for the case of chronic subdural hematoma. In the case of acute subdural hematoma, here we don't use the technique of burr holes. We use the craniectomy. We do a large craniectomy, and we evacuate, we open the dura mater, then we evacuate the acute subdural hematoma. So the craniectomy is used for acute subdural hematoma, and location depends on the location of hematoma. However, in the case of the chronic subdural hematoma, we use the technique of the burr hole. In this technique, some neurosurgeons use one burr hole, and some neurosurgeons use two burr holes. The objective of this burr holes is the evacuation of the chronic subdural hematoma. And it is the same case all those neurosurgical technique follow the location of hematoma. Okay?
Thank you. I do have one follow-up question. In the case of when a craniectomy might be needed, is there a general time frame for when that bone flap can be replaced, or is it more common to leave it off for a long time just to see how often, I guess, the chronic hematoma keeps reappearing?
For the case of subdural, acute subdural hematoma, it is extreme urgent, okay? And we do the craniectomy. In the case of the chronic subdural hematoma, as I said before, we use the bare hose, but if we have the repetition, the recurrence of the chronic subdural hematoma, in the first intervention, surgical intervention, I use the bare hose. In the second one, bare hose. And in the third one, I must use the craniectomy in order to find the origin of the bleeding.
Okay, so the craniectomy wouldn't be used to manage it long-term then.
Okay, thank you very much.
Thank you.
Thank you for the question, Selena. Thank you, Dr. Habchi, for taking the question. We are having two more questions from Daoud. Daoud, can you come up on the screen or unmute yourself at this time, if it is possible for you? Otherwise, we are having a question in the chat box also. Is it possible? Yeah.
Good afternoon. I'm from Nigeria. Thank you, Dr. Habchi, for the presentation. So my question is, you mentioned neurological deficits for arachnoid cyst, and also in acute hematomas, you said that there would be no neurological deficit. So I would like to know what kind of neurological deficits.
So in the case of, you want to know the neurosurgical techniques used for the treatment of arachnoid cyst. This is your question?
No, the deficits, neurological deficits.
So I present to you two cases reports. In the famous cases, the chronic subdural hematoma is the bleeding, the bloods exceed 3 weeks. This is the definition of chronic subdural hematoma. And the evacuation of hematoma, the technique used for the evacuation is the bare hose. This is the definition. But in our cases, in our two cases, we found that we have two origins: an acute subdural hematoma, which in the normal cases disappear after the treatment, after the conservative medical treatment of 1 week. This acute subdural hematoma disappear, but in our cases, after two or 3 weeks, we have the readmission of our patient. So we know that the origin of this chronic subdural hematoma is the acute subdural hematoma. So the history, when we do the history of this patient, we found that he has Alzheimer's disease and alcoholism. So the origin of acute subdural hematoma is the fragility of the vessel, and this fragility of the vessel with the old age of the patient and cortical atrophy all this factor leads to the transformation of the acute subdural hematoma into the chronic subdural hematoma. And the solution here, what is the solution? Is the use of bare-hole techniques in order to evacuate all the chronic subdural hematoma. This is for the first case. For the second case, here, the origin of the chronic subdural hematoma is the rupture of arachnoid cyst. you ask what is the arachnoid cyst? Arachnoid cyst is a cyst. It is a genetic, a congenital disease that appear in some cases, especially the child. So the child, when the child had a trauma, this minimal head trauma causes the rupture of the arachnoid cyst, and the rupture led after 2 weeks of head trauma led to the transformation to a chronic subdural hematoma. And this hematoma created a compression on the brain and led to the emergence of some clinical manifestation symptoms as headaches and also vomiting, augmentation of intracranial pressure, and also he present hemiparesis. Okay, so the origin of the chronic subdural hematoma is the rupture of arachnoid cyst. And so what is the solution? The solution is the evacuation of chronic subdural hematoma through the burr hole. So we evacuate the chronic subdural hematoma through the burr hole, and we recommend to use another technique, neurosurgical technique, which is endoscopic fenestration of arachnoid cyst. Why we use the fenestration, endoscopic or microsurgical fenestration? Why we do this? In order to prevent the emergence or recurrence of another chronic subdural hematoma. So for the chronic subdural hematoma, we evacuate it through the burr hole, and for the arachnoid cyst, we use fenestration. In some cases, fenestration. In other cases, we use shunt between the brain and the periton. This is the surgical solution for the arachnoid cyst. This is my response. I summarize all the cases.
Yeah, I just sent the question on the request of Daoud. He asked to send the question to you.
One
Dr.
question
Habchi,
is about
you-
symptoms.
Yeah. Did you see the question from me in the chat box? Yeah.
For the symptoms, it depends on the location of the hematoma. At the end of our conference, I showed to you one video of 7 minutes. As I said before, the symptom depends on the location of the hematoma. For instance, when we have hematoma in the temporal location, we will have a seizure. When we have in the frontal location, we will have behavior changes. At the end of our conference, I showed to you one video of 7 minutes that summarize all the symptoms. And all the symptoms depend on location of the hematoma. Epidural or chronic or acute subdural hematoma. It depends on the location.
Great. The question was from Dr. Chandraprakash Yadav from our LinkedIn Live. And yeah, okay. So I sent the question from Daoud also, Dr. Habchi.
What are the What are some of the neurological deficits that can accompany the arachnoid cyst? Okay, for the arachnoid cyst, the most location is the temporal location. We noticed that almost of our patient present a seizure when they have arachnoid cyst in the temporal location. They present a seizure.
Right. I hope the answer is satisfactory to Daoud now.
And okay, yeah. And also we noticed that when we have a great cyst. When the size of arachnoid cyst increase, it differs. We have the hypertension, intracranial hypertension, and the symptom of intracranial hypertension is headache and vomiting. This is the most characteristic of intracranial hypertension. For the case of arachnoid cyst.
Thus, we got the add-ons also. Thank you so much for taking the questions, Dr. Habchi. Let me ask any more questions for now from Dr. Habchi, from any of you.
Suggest for arachnoid midline and presentation on different symptoms. So, for the case of arachnoid cyst with neurological symptoms, the recommendation is cystoperitoneal shunt is the technique. And also we use the fenestration, another technique. We use the shunt, cystoperitoneal shunt, if we have recurrence of a neurological symptom, or the endoscopic fenestration. This is the solution for the neurological symptom that appear with arachnoid cyst. But it is not at the first level. Most of our patients, we treat the neurological deficit. We gave them some anti-seizure medicament in order to treat the seizure, but we follow them every 3 or 6 months. But when we have the repetition of recurrence of this neurological symptom, and in some cases we have the hydrocephalus, in these cases we are obliged to do the cystoperitoneal shunt or the fenestration, endoscopic fenestration. This is the response to Condra PACHA.
Yeah. Thank you so much for taking the question from Dr. Chandra Prakash as well, Dr. Habchi. That was the question from LinkedIn Live, which we are doing right now. Okay. So any more questions from any of our attendees here? Or we should keep the questions for later, as Dr. Habchi will share some important videos also, some informative videos also after the talk from Professor Daoud. Yeah. So with your permission, Dr. Habchi, shall we move to the next talk, and then we will continue the questionnaire later at the end.
Okay.
Yeah, thank you so much. So everyone, let me announce our next speaker, our next presenter, Professor Daoud.
Yes. Yeah. Good day, everybody. I hope you are fine.
Definitely. Thank you so much, Professor. Have a good day to you too.
Yes.
Yeah. So everyone, Professor Daoud will explain the extradural hematoma, its diagnosis and treatments.
Can you see my screen?
Perfectly, yes.
Yes. Can you see my screen?
Yes,
Yes.
Professor.
Yes.
Yes.
So we are going to talk to you today about one of the most important neurosurgical pathologies, which is extradural hematoma. So we will talk about its diagnosis and its treatment and its prognosis. So we start with the first question. What is an extradural hematoma? Extradural hematoma, also known as an epidural hematoma, is a collection of blood that forms between the inner surface of the skull and outer layer of the dura, which is called the endosteal layer following a head injury. So, extradural hematoma is acute hemorrhage, is a collection of blood between bone and dura mater. In order to understand the definition and the consequences of an extradural hematoma, we need to understand the normal anatomy. So, our brain is encased in 3 meningeal layers, which are from outside to inside the dura mater, the arachnoid, and the pia mater. Between this layer, we find space. The subdural arachnoid space is found between arachnoid and pia mater. In this space, we found the cerebrospinal fluid. Between the arachnoid and the dura mater, we found a subdural space, a potential space, and with between the bone and the dura mater, we found the extradural space. The extradural space is a virtual space. So in this space, we don't find any blood, no blood, and no liquid. Note, extradural hematoma are not confined to the cranial vault and can happen in the spinal cord as well. When this condition occurs in the spine, it is known as spinal epidural hematoma. Spinal extradural hematoma or spinal epidural hematoma is a collection of blood in the potential space between the dura and bone. Along the spinal, is the collection of blood in potential space between dura and the bone. Along the spine here, the spinal canal into the epidural space. This may arise spontaneously during childbirth or as a rare complication of epidural anesthesia or surgery. Here we have some generality about the extradural hematoma. Extradural hematoma is an extreme neurosurgical emergency, but fortunately, it's a rare pathology in neurosurgery. This pathology represents 1 to 4% of all complications of head injury. Extradural hematoma is a pathology, is one of the pathology affects young people, rare after age 60 years. The cause is typically head injury and bleeding from the middle meningeal artery. Diagnosis is typically by a CT scan. Treatment of this pathology is generally by urgent surgery. Without treatment, death typically results. So it's an extreme neurosurgical. The mortality of this pathology is between 20 and 55% according to the most recent series in the literature. Prognosis of the extradural hematoma depends on speed and the quality of the initial management of this pathology. Here, the time is prime. It's an extreme neurosurgical emergency. The next question, what causes epidural hematoma? So extradural hematoma is usually caused by head injury, head trauma, mostly due to 1, car accident, road traffic, 2, false, accidental or criminal or suicidal, 3, sports-related accidents, 4, assaults by firearm or by knife. Note, you can also develop an extradural hematoma from no trauma cause. When these causes include infections, coagulopathy, when we have a coagulopathy, when our blood does not clot as normally should. In hemorrhagic tumors, when tumors that cause bleeding, and in the case of vascular malformation, for example, include arteriovenous malformation and the cavernous malformations. Next question, what is the pathology of extradural hematoma? In order to understand the consequences and the pathology of extradural hematoma, so we need to understand the physiology of the Morrow-Kelly doctrine. The Morrow-Kelly doctrine, yes?
Hello, yeah, I'm sorry for interrupting, Dr. Daoud. Can you please turn off your alarm, as it may hinder the recordings later. Thank you so much. I'm sorry for the hindrance.
Yes, yes. Sorry for this interruption. Yes.
That's fine. I loved it how you were so focused in your task.
It's not mine. It's not mine.
Yeah.
So yes, we talk now about the pathology of extradural hematoma. In order to understand the consequences of and the pathology of extradural hematoma, we need to understand the physiology of the Morrow-Kelly doctrine. What's Morrow-Kelly doctrine? Morrow-Kelly doctrine states that the skull is a closed vault, and the sum of the brain parenchyma, cerebrospinal fluid, and blood is constant. Into the skull, we have 3 volumes: brain parenchyma, blood, and CSF, cerebrospinal fluid. The total volume is constant. It is a pressure volume relationship. If one of these 3 increases, then either or both must decrease in order to compensate. In the case of an extradural hematoma, the presence of extra blood exerts mass effect, and this can be potentially lethal as it can cause. As the volume of blood flowing from the damaged blood vessel into the extradural space increases, it begins to loosen the outer layer of the meninge, the dura mater, from the skull or the bone. If the extradural hematoma continues to grow, the pressure inside the skull, intracranial pressure, also increases. If left untreated, this increased pressure can damage the brain through midline displacement, brain shifts. Look here, the brain shift or displacement of brain, and tontorial herniation. Increased intracranial pressure will lead to brainstem compression, and we have death of the patient. Next question, where is this bleeding coming from? What is the origin of this collection, the source of this collection? So the source of the bleeding is typically arterial. Usually we have the middle meningeal artery in 75%. The middle meningeal artery is typically the third branch of the first portion of the maxillary artery. After branching off the maxillary artery in the infratemporal fossa, it runs through the foramen sphenium to supply the dura mater, the outer meningeal layer, and the clavaria. The middle meningeal artery is the largest of the three paired arteries that supply the meninges. The other being the anterior meningeal artery and the posterior meningeal artery, the three parts. Occasionally, an extradural hematoma can form due to venous blood, typically a torn sinus with an associated fracture, cyst sinus extradural hematoma. Location. Extradural hematoma are generally unilateral in more 95% of cases. However, bilateral or multiple extradural hematomas are reported in literature. So, more than 95% are supratentorial, temporoparietal in 60%, frontal in 20%, and parieto-occipital in 20%. Less than 5% are located infratentorial, so in posterior fossa. Special location to consider, particularly those related to venous bleeding. An extradural hematoma, An extradural hematoma is commonly caused by skull trauma in the temporoparietal region, typically following a fall assault or sporting injury, and an extradural hematoma is associated with a skull fracture in 75% of cases. The pterion here is an anatomical landmark where the parietal, frontal, sphenoid, temporal bones fuse. The pterion is particularly vulnerable to fracture as the bone at this location is relatively thin. The middle meningeal artery also is underneath the pterion, and therefore fracture at this location can result in rupture of the middle meningeal artery. As a result, the middle meningeal artery is involved in 75% of extradural hematomas. Extradural hematoma can also occur secondary to the rupture of the vein, particularly if the middle meningeal vein or dural sinus are involved. What are the symptoms of any dural hematoma? So, when a person has epidural hematoma, they experience brief loss of consciousness after the head trauma. This is followed by a period of alertness that may last for several hours before a loss of consciousness and brain function decline. In some people, loss of consciousness leads to keep in mind that most, but not all people with extradural hematoma follow this symptom pattern. Other signs and the symptom of an extradural hematoma, which occur minutes to hours after the head injury, include severe headache, Why we have severe headache after hematoma, extradural hematoma? This pain is caused by the stripping of dura from the bone by the expanding hemorrhage. Nausea and vomiting in relation with the increase of the intracranial pressure, enlarged people in one eye. So here, black center area of the eye is big. Confusion, slurred speech, dizziness, weakness on one side of the body. If left and bleeding continues, brain pressure increase and the symptoms can get worse. Possible symptoms at this point include seizures, breathing problem, loss of brain function, coma, and death. Here we have the Glasgow coma scale in clinical is a clinical scale used to measure a person's level of consciousness after a brain injury. This scale composed of 3 tests: eye, verbal, and the motor responses. The score for each of these tests are indicated in the table. A person's with Glasgow score can range from 3 to 15. Also, this scale it's used to give immediate medical care after brain injury. Next questions. How is an epidural hematoma diagnosed? A CT scan is the gold standard investigation in cases of suspected intracranial bleeding. The investigation should be requested urgently if intracranial bleeding is suspected. So, extradural hematoma here on a CT scan, we have this figure on CT scan. Head is biconvex or biconvex or lentiform shape, hyperdense. Also, secondary feature on CT scan head can include midline shift, and brainstem herniation, both of which are indications for early surgical intervention. Also, CT head scan showing the fracture of bone. Here we have a case of extradural hematoma. Is 20-year-old patient presented with scaffolding accident without helmet, without protection of head trauma. So this patient presents head trauma. 2 hours later, the trauma disturbances or alertness appeared. On admission to the emergency room, the patient was drowsy and obnubilated with score 13. CT scan, on CT scan, so we have here a left temporal extradural hematoma, biconvex hyperdense. Here we have the left temporal fracture, and on the 3D bone reconstruction showing the temporoparietal fracture line here. The second investigation, MRI head, has little benefit over CT and take much longer to perform the scan, making it less ideal in the acute context. MRI can be used in the subacute setting to assess for evidence of underlying cerebral contusions, ischemia, or diffuse axonal injury. Acute extradural hematoma appears iso-intense on T1 and shows variable intensities from hypo to hyper-intense on a T2 sequence. Early subacute extradural hematoma appears hypo-intense on T2, while late subacute and chronic extradural hematoma are hyper-intense on both the T1 and the T2 sequences. The third investigation, skull X-ray, is not typically used in the investigation of extradural hematoma. However, if skull fracture is noted, like here, on skull X-ray, a CT scan head should be performed urgently to assess for evidence of extradural hematoma. The next investigation, cerebral angiography, may be used in the subacute setting to assess for an underlying arteriovenous malformation, which may be the cause of the extradural hematoma, but in condition if there was no history of trauma. The form clinic, so the symptomatic forms lacking a free interval immediate coma with or without focal signs, persistent post-traumatic obnubulation, form depending on time of onset. Some extradural hematoma are revealed within 2 to 3 days or even 15 days. Incidentally, recovery, surgical emergency with good prognosis. Topographical forms, we have 4 forms. A frontal extradural hematoma, best tolerated subacute course, gives rise to confusional syndrome, intracranial hemorrhage. The second location, temporal extradural hematoma, large because the lesion involves the trunk of the middle meningeal artery. The free interval is short. Temporal involvement is rapid, leading to a poor prognosis. Third location, vertex extradural hematoma. Rare lesions are venous, usually sinus progression is subacute. Extradural hematoma of the posterior fossa, the fracture of the occipital skull crosses the lateral sinus on the skull X-ray. Its sudden onset leads to a dramatic picture, major intracranial hypertension, and finally involvement of the brainstem. The forms according to the patient in children. So in children, the free interval is often very short and the fracture line may be missing. In infants, we have anemia, the clinic dominated by the signs of anemia. In the elderly, pathology, this pathology, extradural hematoma, is rare due to hard dura bone. Adhesion, it may be associated with other cerebral lesions. In alcoholics, the diagnosis must be evoked systematically, even the presence of conscientious disorders. How to differentiate between extradural hematoma and the other subtypes of intracranial hematoma? What the difference between extradural hematoma, a collection of blood in extradural space, and other collection of blood in intracranial? So we have here we have subtypes of intracranial hemorrhage differ in their clinical presentation, and radiological appearance. So we have 4 subtypes. We have extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and intracerebral hemorrhage. We start with the location. Extradural hemorrhage, the collection or the blood collection is between the bone and the dura mater. In subdural hemorrhage, the collection is between the dura and the arachnoid mater. In subdural arachnoid hemorrhage, the collection or the blood collection is located between the arachnoid and pia mater. But about intracerebral hemorrhage, the collection is within the brain parenchyma. What about the pathology or the origin of this bleeding? In extradural hematoma, we have a rupture of middle meningeal artery. In subdural hemorrhage, we have the rupture of the bridging cranial veins. In subarachnoid hemorrhage, rupture of we have a rupture of aneurysm. Aneurysm is a malformation of vessels of skull. In intracranial hemorrhage, we have the case of a hemorrhagic stroke. About the symptomatology, in extradural hemorrhage and in subdural hemorrhage and subarachnoid hemorrhage, we found the history of trauma. So these 3 types, we have trauma or head trauma or head injury. But in the intracerebral hemorrhage, we have a sudden onset of neurological deficit. We don't find a history of trauma or a history of head injury. What about the diagnosis? The extradural hemorrhage done on CT scan, we have a hyperdense biconvex shape. In subdural hemorrhage, here we have 2 types: acute subdural hemorrhage and chronic subdural hemorrhage. So in the acute subdural hemorrhage, we have a concave hyperdense shape. But in the chronic subdural hemorrhage, we have a concave hypodense here. In the subarachnoid hemorrhage, here we have hyper attenuation around the circle of Willis. Here we have hyperdense around the circle of Willis. In the intracerebral hemorrhage, we have hyperattenuation. This is intracranial hemorrhage in the brain parenchyma. So this is the difference between this subtype of intracranial hemorrhage. Next question: what are the treatment of epidural hematoma? The management of this pathology. So, extradural hematoma is any emergency condition. Treatment goals include taking measures to save the person's life, controlling symptoms, minimizing or preventing permanent damage of brain. So, surgery, first surgery, the preferred surgery is craniectomy and hematoma evacuation, craniectomy and evacuation of hematoma. This means removing the blood clot, stopping any obvious sites of bleeding. then putting the skull bone back in place. We put this in place after evacuation of the hematoma. The second option, another surgical approach, is a drill all or more holes in skull to drain the blood. Yes. Draining the blood relieves the pressure the blood build up causes on the brain. The drain may be left in place for several days following surgery to allow the blood to continue draining. Note, if you have a spinal epidural hematoma, we realize laminectomy may be performed. During a laminectomy, a small section of bone is removed. Removed bone relieves pressure on your spinal cord and nerve roots caused by the blood clot. Postoperatively, patients should be observed on either a neurocritical care or a high dependency unit with the close neuro observations and routine post-operative CT scans to ensure adequate clue removal. Ongoing neurorehabilitation is often required. If brain damage, neurologists will order to needed therapy, physical therapy, occupational therapy, and or speech therapy. Complications of surgery include infections, wound infections at the incision or deeper infections, including meningitis or osteomyelitis. Brain herniation, increased pressure can squeeze and push brain tissue so it moves from its normal position. A brain herniation often leads to death. Bleeding may be superficial or deeper and be repeat hematoma that require removal again. Seizures may develop even after a hematoma has been treated. Brain or spinal cord damage can occur and if evident by weakness, numbness, and or paralysis, coma, or death. Conservatively treatment, a small conservatively treatment when we don't operate this collection. A small extradural hematoma with no major symptom may be treated conservatively, so not have any operation, as the clot can often reabsorb on its own. We'll have to stay, so the patient will have to stay in hospital for close observation and have further CT scan during this time to ensure that there is not further bleeding. Medicine is used in addition to surgery will vary according to the type and the severity of the symptoms. So we use osmotic diuretics such as mannitol or hypertonic saline may be used to diminish intracranial pressure. Hyperthermia may exacerbate neurological injury. Anti-seizure medicine may be used to control or prevent seizure. Patients with spinal epidural hematoma may require a high dose of corticoid when spinal cord compression is involved. Immobilized patient may require heparin for prevention of venous thrombosis, whereas vitamin K and protamine may be administered to restore normal coagulation parameters. Antacids are used to prevent gastric ulcers associated with traumatic brain injury and spinal cord damage. Management for treatments. So the indications. As discussed, majority of extradural hematomas are traumatic in nature therefore should be managed as per the Atlas protocol. Once the patient has been stabilized and the extradural hematoma is confirmed, your urgent neurosurgical opinion is required. Current management guidelines from the Brain Trauma Foundation suggest that not all extradural hematomas require surgery. More than 30 centimeter clear should be managed surgically regardless of other factors. Less than 30 centimeters square with low thickness, minimal midline shift, and score of Glasgow more than 8 without any focal neurological deficit are candidates for conservative management. Conservative management typically involves serial CT imaging and close neurological observation. Prognosis. The prognosis of this pathology of the extradural hematoma. So the overall mortality rate is around 30% in the literature. Risk factors for poor prognosis include increasing age, temporal location, low score of Glasgow and presentation, and evidence of herniation or raised intracranial pressure. We have here some key points. So extradural hematoma are typically traumatic and arterial, occurring most commonly in young men. Classic presentation is of a lucid interval, then rapid progression to signs of raised intracranial pressure and herniation without intervention. CT scan will show an area of hyperdensity that is convex and does not cross the suture lines. Can be managed conservatively or surgically depending on a number of factors, including size, midline shift, and the score of Glasgow. Thank you.
Thank you so much, Dr. Daoud. And that's how Professor Daoud concluded the diagnosis and treatments of extradural hematoma. And that part was very impressive for me when you asked the questions. The questions we might ask you and you answered them. That was really appreciated. And let me ask if any of our attendees have questions to be asked from Professor Daoud. If you are having any questions, anything you would like to discuss with Professor Daoud, please go for it.
Good evening.
Good evening.
She said something about drilling holes in the brain during the treatment. During that period of drilling hole, if the brain starts to clot back, what is the adequate treatment or remedy that can be done at that point. The blood, when the blood flows out, because when you drill through the brain, the blood flows out, then it starts clotting back. What can be done at that point?
I
I'm
can't,
sorry. Yeah.
please repeat your questions. It's about.
Can you
I
write
said
your question in the part of the discussion if it is
Yeah,
possible?
okay.
Thank
It's
you so
about.
much, Mr. James.
It's about the symptomatology of the management of the hematoma extradural hematoma. Please.
Mr. James will write down the question in the chat box.
Ukasha,
Yeah.
can you write your question in the part of the discussion? So your
Yes.
Professor Daoud can give you the response.
It's ideal if he writes her question in.
As Selena, she write very interesting question for the management of chronic subdural hematoma. So I gave the response in the part of the discussion. She mentioned old technique, the placing the drainage tip in the space in order to evacuate the hematoma. So this techniques is abandoned because of the infection caused by this technique. And actually we use the techniques of the burr hose, one burr hose or two burr hose. And for Okasha, is anti-edema measure indicated in all
Yes, anti-edema
cases?
in all each cases. Affect. About the treatment of the anti-edema measure, so we use treatment of edema after evacuation of the hematoma. If you use the treatment of edema, we can enlarge the extradural hematoma. Keep attention.
So the question was from Shiva Kumar, neurosurgeon, and that was from LinkedIn Live.
So in the management of the treatment of extradural hematoma, we use craniectomy to in the goal to evacuation of the hematoma. The evacuation of when we evacuate the hematoma, we have two goals. The first, hemostasis, and the second, we decrease the pressure, the intracranial pressure. So the high pressure, the high intracranial pressure, or all symptoms in extradural hematoma is in relation with the increasing of or decreasing of the pressure into the skull. What is lucid interval? The symptom of extradural hematoma, the typical picture is loss conscience after head injury, patients present loss conscious. After we have patients without trouble of conscience. After we have installation of the neurological perturbation. This time between the first trouble of conscience and the second trouble. We name this interval lucid interval. This is the typical pictures or typical symptoms of extradural hematoma. But not all patients present this picture. Other situation, we don't find this picture. We find other signs. Have you worked with any physical therapist in multidisciplinary team managing? Can you please help me? Can you please? What it all was. So, in the management of or the treatment, the treatment of the hematoma extradural, we have surgery, we have medicine, and we have other types of treatments. In goal or two study in goal to correct the deficit or the trouble caused by this pathology. When we have an extradural hematoma, we have a collection or blood collection between the dura mater and the bone. This collection comprehend the brain. Dependent to the location of this compression, we have symptoms. For example, when we have a compression of the frontal parts, we have a psychology troubles. So the patient need after surgery and after medicine treatment need a psychology treatment. Yes. During hole in the brain to allow draining of the blood. If the blood clots and covers the hole, what will be done at this point? Drilling holes in the brain to allow draining of the blood. If the blood clots and covers the hole, what will be done at this point? About the treatment of the extradural hematoma, the ideal treatment is craniectomy. The indication of hole, it's not numbers. We use this technique of hole if the patient presents other pathology, for example, coagulopathy or other. But the ideal or the best is the craniectomy. The hole is rare, the realization of this technique is rare. And this technique has the condition. For example, we talk about the all. So you use another all and deblock this. Drilling holes in the brain to allow draining of the blood. PACHA. Other questions?
Do we have more questions from Dr. Daoud? Dear team.
I have read articles about boric acid treatment for these brain injuries but I don't know if it is valid for hematoma. Are there treatments with boric acid antiparticles today for those who do not have major symptoms? Extradural hematoma is an extreme neurosurgical emergency. So time is brine in this pathology. We can use other treatments. The first treatment is surgery. When the extradural hematoma is diagnosed, we must operate the patient. We must use the evacuation of this hematoma. Why? Because this collection comprimes the brain. Brain suffer. The sufferance of this brain. So the treatment is surgery. So the few cases when don't use the surgery, when we have small symptomatology, we haven't paralysis, we haven't a symptom of high pressure intracranial, we don't use surgery, but in condition patient in hospital with a serious observation and used and release a CT scan. So is emergency neurosurgery pathology. How do you not have major symptoms?
All right. Dear team, please share if we are having any more questions. And of course, thank you so much to all those who are asking the questions for your questions, and Professor Daoud for your answers. Okay. There's a question from Mohammed Khamoshi from LinkedIn.
Please explain about the rehabilitation of patients. Yes. In some cases, patients with extradural hematoma develop a paralysis. Why? Because this collection comprises in the area responsible to this member. Yes. So in the cycle of this extradural hematoma, we have sometimes deficits. So after surgery and after the compression of this brain, a patient necessitates this rehabilitation. So we orient this patient to rehabilitation to recuperate his deficit. And the goal to recuperate his deficit. It's another option or another etap in the management of this pathology.
Right?
I hope he understands me.
I definitely did. And yeah, if you are having any more questions, Mr. Mohammed Khamoshi, please let us know. And please let us know if you didn't get any point from Dr. Saad. As in my opinion, Professor Saad is answering the questions in a very simple manner. But still, we do understand the language barriers. It's very common, right? When we are talking with people from different countries, and here are people from so many different countries connected in our today's meeting. It's very common. It's understandable. Any more questions? Please let us know. All right. So for now, till we get some more questions, with your permission, Professor Daoud, can we go to the videos Dr. Habchi was mentioning about? Yeah. As I think so many of the questions will be answered through videos.
I downloaded the video on a purpose to fully understanding the symptom and mechanism of disease, and also to show you some neurosurgical techniques. I share with you video.
Sure.
The first one is about the symptoms. Can you see the video?
From my end, it hasn't started yet. Yeah.
Okay.
Yes.
This is the first one. The effect of damage of the brain. It depends on the location.
Of the brain. Deals with the skills and functions associated with the lobes of the brain. There is the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe, and the cerebellum. Associated with the frontal lobe are various controls. It controls certain of our behaviors and certain of the things we do. And when it's injured, that has certain consequences. The changes that are seen when there's an injury to the frontal lobe include problems with sequencing, perseveration, where there's difficulty making decisions. People experience decreased attention, changed personality, problem-solving difficulties, a decrease in their ability to verbally express themselves, a lack of spontaneity, uncontrolled emotions, social and sexual behaviors, decreased initiation of voluntary movements. The changes that we see when the temporal lobe is injured is that people have problem understanding the spoken word. There are problems with selective attention. Sexuality changes. A person with a temporal lobe injury may be found to persistently talk. And often with a temporal lobe injury, we see an increase in aggressive behavior. There are problems identifying objects and categorizing them. And there are problems recognizing faces and finding objects. So now let's talk a little bit about the parietal lobe. The parietal lobe is an area of the brain that takes us into sort of a higher level of functioning. And as we look at the parietal lobe and those changes, we see in patients with traumatic brain injury difficulty naming objects, problems processing their tactile sensations, so problems processing and understanding what their fingers are telling them they're touching. You see people's academic skill sets fall, and things that they were easily able to do in the workplace or in the academic setting from a cognitive standpoint are now diminished or gone. There's confusion between the left and the right. You have a loss of hand-eye coordination and a decreased orientation of where our bodies are in space. Often when I see a client who has damage in the occipital lobe, I see issues of vision defects. There's loss of the visual field. There are problems visually locating objects. And importantly, there are problems identifying colors. People can have distorted vision, hallucinations. They can have something called word blindness. There's the inability to perceive the way that objects move. And obviously there are problems with reading and writing. And there's an overall slowed processing of the way that our brains process visual information. So when we look at the cerebellum, and that's the area here really at the back and the base of the brain and at the top of the spinal column, as we look at the cerebellum and we look at the types of things that our cerebellum does for us each and every day, we see things like the following. We see the control of gross and fine motor coordination. We see all of our voluntary motor coordination. So when we decide we want to reach out and grab a jar off the shelf, we put our arm out and we do that, and that's our cerebellum in action. We have our balance and our equilibrium, the ability to stand up and not fall over, the ability to be able to ride a skateboard, to be able to ride a bicycle, to go for a jog down the block. Our postural control and our eye movements, moving our eyes back and forth, up and down, and utilizing our eyes to obtain visual information so that it can be processed by our brain. So our brainstem controls so much of what happens in our body. It controls so many of the different functions that allow us to survive as human beings. It is an area of the brain that really we take for granted, and we should be able to take for granted. But when it becomes injured through an accident or whatever, the brainstem and the injuries that flow from that can have horrible consequences for us. Let's take a look at what some of those might be. When a person has an injury to their brainstem, we see the damaged regulation of our ability to hold our body temperature, to keep it at a healthy temperature as opposed to getting too hot or too cold. We can lose the ability with injury to the brainstem, efficient, effective management of our heart rate or the rate at which we breathe. People with injuries to their brainstem also experience problems with balance and with their movement. They have problems with swallowing food and liquids, something each of us should be able to take for granted. Brainstem injuries classically can be associated with symptoms of vertigo, where the world spins, and often it's uncontrollable and unfixable. There's dizziness and there's nausea. So we've now had an opportunity to talk about the different lobes of the brain, what the different lobes of the brain control in terms of each of our lives, in terms of all the different aspects of our physical life, of our emotional life, of the way we think, the way we process information, down to issues when we're talking about the brainstem, for example, of just how we swallow food, how our body regulates our temperature. When any of the lobes of our brain is damaged or injured, either by an accident, by a driver, by a drug, by a doctor, it is a horrible consequence. It affects our lives in myriad ways.
This is the first video. It's about the symptom. I showed it for the attendee who asked about the symptom. As I said before, the symptoms depend on the location of the lesion. The first video is the longest one of 7 minutes. The second one is about the arachnoid cyst. What is arachnoid cyst? Because some person ask what is the etiology of arachnoid cyst and the management, surgical management or conservative management. Look to this video. At what time we do the surgical management, fenestration, endoscopic fenestration, or a placement of a shunt. hematomaArachnoid cyst. Now we pass to the surgical techniques. Craniotomy and craniectomy. Look here, the difference between them.
Your doctor may recommend a craniotomy or craniectomy procedure to treat a number of different brain diseases, injuries, or conditions. Your skull is made of bone and serves as a hard protective covering for your brain. Just inside your skull, 3 layers of tissue, called meninges, surround your brain. The thick, outermost layer is the dura mater. The middle tissue layer is the arachnoid mater. And the innermost layer is the pia mater. Between the arachnoid mater and the pia mater is the subarachnoid space, which contains blood vessels and a clear fluid called cerebrospinal fluid. Blood vessels, called bridging veins, connect the surface of your brain with the dura mater.
This is the causes of subdural hematoma.
Other blood vessels, called cerebral arteries, bring blood to your brain. Inside your skull, normal brain function requires a delicate balance of pressure between the blood in your blood vessels, the cerebrospinal fluid that surrounds your brain, and your brain tissue. This is called normal intracranial pressure. Increased intracranial pressure may result from brain tumors, head injuries, problems with your blood vessels, or infections in your brain or spinal cord. These conditions put pressure on your brain and may cause it to swell or change shape inside your skull, which can lead to serious brain injury. Your doctor may recommend a craniotomy to remove abnormal brain tissue, such as a brain tumor, a sample of tissue by biopsy, a blood clot called a hematoma, excess cerebrospinal fluid, or pus from an infection called an abscess.
Indication of craniotomy.
A craniotomy may also be done to relieve brain swelling, stop bleeding called a hemorrhage, repair abnormal blood vessels, repair skull fractures, or repair damaged meninges. Finally, a craniotomy may also be done to treat brain conditions such as epilepsy, deliver medication to your brain, or implant a medical device such as a deep brain stimulator. The most common reason for a craniotomy is to remove a brain tumor. Before your procedure, you will be given general anesthesia to make you unconscious and pain-free. The skin on your scalp will be shaved over the location of the tumor. To begin, your surgeon will make an incision in your scalp. 1 or more small holes will be made in your skull. Then your surgeon will connect the holes to create a circular piece of bone called a bone flap and remove it. Your surgeon will make an incision in the dura mater to expose your brain. Then your tumor will be removed. The incision in the dura mater will be closed with sutures. Your surgeon will reattach the bone flap with metal plates and screws that will remain in your skull for life. You may have a variation on a craniotomy called a craniectomy if your brain is very swollen or your skull is infected. Your surgeon may delay reattaching the bone flap until a later procedure to allow time for the swelling to go down. At the end of either a craniotomy or a craniectomy, your scalp incision will be closed with staples, and your head will be wrapped in bandages. If you had a craniectomy, you will have another procedure called a cranioplasty at a later date after the swelling goes down. At that time, your surgeon will reattach your bone flap with metal plates and screws. Then close the skin incision with staples. After either procedure, you will stay in the hospital for several days. Your caregiver will check your brain function by asking you questions and shining a light in your eyes. You may be given medication to prevent complications.
This is a demonstration of craniotomy. Now you see the technique on a head trauma victim. Okay. Surgical management of acute subdural hematoma. This is a radiological characteristic of acute subdural hematoma. Look here, the steps of the surgery, first steps. This is the skin, and this is a bone. This is the burr hose, and this is the craniectomy. Now we pass to the opening of dura mater. This is the dura mater, opening of dura mater. This is the acute subdural hematoma. This is the aspect. Now the evacuation and the use of this in order to evacuate the hematoma. This is the water. Now we search the origin of the bleeding. Coagulation here. This is the aspect of the brain after the evacuation of subdural, acute subdural hematoma. Now we pass to the techniques of using of the burr hose. The case of chronic subdural hematoma. This is a video of Ricardo Comotor and his team.
Junction with Sander Connolly, leading you through burr holes for a subdural hematoma. The patient is positioned supine with their head turned and elevated on a cerebellar headrest. A shoulder bump may be used to aid rotation. Perioperative antibiotics are administered. Burr hole placement depends on the case characteristics, but in general, 2 linear incisions are marked, each approximately 2 to 3 centimeters in length and 1 to 2 centimeters above the superior temporal line. The anterior incision should be just behind the hairline, and the posterior incision should be 2 centimeters behind the ear. A small shave is performed, and the surgical field is prepped and draped in usual fashion, including sterile towels, IABAN, and split sheets. A linear incision down to bone is made at the anterior mark first. A periosteal elevator is used to expose the skull. A small Wheatlander retractor is placed, and hemostasis is obtained. Using a high-speed perforating drill, a burr hole is placed at the desired location. Bone edges are waxed, and the dura is bipolared. Attention is then turned to the posterior incision, where the same sequence of events is completed. Once meticulous hemostasis is obtained at both sites, the dura is widely opened in a cruciate fashion at the anterior burr hole first. The subdural hematoma is then partially evacuated. Next, the dura is widely opened in a cruciate fashion at the posterior burr hole. Once both sites are opened, the subdural is fully evacuated using a combination of suction and irrigation. Care must be taken to not damage the brain surface, which should be visible through the burr holes. Subdural membranes may be excised depending on their attachments. Once the hematoma has been adequately evacuated, as indicated by clear irrigation exiting the burr holes, closure is commenced. Meticulous hemostasis is obtained. The subdural space is filled with irrigation. Burr hole covers are secured. A subgaleal drain that runs over both burr holes is placed, exiting posteriorly. The wound is generously irrigated to remove debris and devitalize tissue. The scalp is closed with 3/0 vicryl stitches at the galeal level and staples to reapproximate the skin edges. The wound is properly dressed with bacitracin ointment, Helfa, and Tegaderms.
For the irrigation and the washing of the hematoma, we use saline serum, or in some cases, in the emergency, we use the distillated water. These are all the video that I can share with you in order to understand the symptom of the disease, the mechanism of disease, and the surgical techniques used in the management of acute subdural hematoma and the chronic subdural hematoma. I hope that you have some ideas about surgical management of these kinds of hematoma.
Thank you so much to Dr. Habchi for these intuitive videos and clearing any remaining doubts if there were.
Thank you for you. Thank you for the very interesting question about the attendancy. So they pose a question about rehabilitation, about surgical techniques. It's a good.
Yeah, we found our attendees quite attentive today, right?
Yes. So
That's what we
like
love.
they understand this pathologist. I hope that they understand the
We did.
difference between chronic and acute subdural hematoma, this first information, and also the management of epidural hematoma, the conference of Professor Daoud.
Definitely. I'm sure everybody did. And even Professor Daoud, she were for the very first time, right? She were here on this platform. Yeah. And let me inform to everyone. Dr. Habchi introduced Professor Daoud to us.
Yes.
Yeah, thank you so much for bringing such a knowledgeable speaker to us. And thank you to you too. Okay, so I'm having some announcements to make here, right? So very first announcement I already made. It's about sharing your full name and your email address. And this information will be used for the certificates preparations, right? So please do share these details in the chat box, as certificates will be provided to all those attendees and speakers who have registered for the event and who have attended the event for at least 70% of the duration. Yeah. Okay. So let me share the discussion group link also here. So in case you find any more questions to be asked from Dr. Habchi and Professor Daoud, you can simply write down the question there, and we will definitely try our best to get the questions for Dr. Habchi and Professor Daoud and get the answers for you. Here I have shared the direct link for the discussion group. Dear team, please make sure you share the discussion group link on the LinkedIn Live as well. And yes, there is a good news, as we are about to cross 1,000+ views on our LinkedIn Lives, and 10,000+ hours of LinkedIn Live are almost crossed. So we are very thankful to all these viewers, attendees who are supporting all shares. Okay. I hope everybody has shared their full name with their titles, as it is Mr., Miss, Doctor, Professor, right? And your email address here in the meeting room. Discussion portal link has been provided. Any question you are having, please make sure you ask the question in the discussion portal and we will get the answer to you. Okay, and yeah, Mr. Doughton was asking for the slides. So you can send them email to Dr. Habchi, and Dr. Habchi will share the slides with you if she is willing to, right? So Dr. Habchi, would you please mind if I ask you to please share your email address, so that all those who wants the slides from you, and also Professor Daoud also, please share your email address if you are willing to share your slides with the attendees. I repeat, only if you are willing to share your slides with the attendees, please share your email address in the chat box. And all those attendees who are interested in getting the slides of your presentations, they will contact you. Yes, email addresses are also available at Scientific Program on our website. Yeah, Scientific Program for this very event. You can get the email address from there also. The link for Scientific Program has been shared. in the meeting room. Okay. And we are having an all share live conferences LinkedIn group also. So all those people who are connecting with us from LinkedIn, you can connect with us from that group also, as we keep updating about our upcoming events, about upcoming speakers, and all those things on that group. So if you're interested, all the informations are provided at our LinkedIn profile. And if you can't find the group, you can simply message us and we will add you in the group. Or let me just share the direct link in the meeting room also. And dear teammate, please share the link in the LinkedIn Live also. Here, I am sharing that direct link for LinkedIn Live, LinkedIn group. Just in case you want to get connected from a single platform, this is in that case. Also, there is one more announcement. For all those attendees who are participating actively, our committee, from the last two events, our committee is selecting such attendees and providing them certificates, even though they haven't registered or they have registered. The committee is providing the free registration up to $150 to such attendees for any of our upcoming future events. Okay, I got the update. It's the free sponsored ticket of between $25 to $250. The committee is sponsoring the tickets to such attendees who are actively participating. The committee is selecting such attendees. All right. I would like to share that the certificates will be provided by the next 3 working days of this event. That is Monday, Tuesday, and Wednesday, as today is Saturday. Right now it's Saturday in India. We will provide the certificates by Wednesday evening. And if you have attended the event and shared the details in the meeting room and registered for it, and you didn't get the certificate by any chance, you can contact me at any of our platforms on our website, Facebook, LinkedIn, Insta, Twitter, on our YouTube, on our WhatsApp. Okay. Okay. With that, let me announce about our next event. The next event will be, let me share the direct link for the next event. Dear teammates, please make sure you are sharing these links on the LinkedIn Live as well. All right. And also, your precious feedback and suggestions are welcome from all share side. Please make sure if you are having any suggestions for us, any feedbacks, please make sure you share with us. We are glad, Adriana King, that you had a great informative time in the meeting and hope to meet you again in future. Here I have shared the direct link for our next event, which is degenerative nerve diseases live conference. And the event will be on 7th October. I repeat, it is on 7th October, the same time, will start at 8 p.m. Indian Standard Times. Okay. Any information you want from our side, please let us know. Any questions you are having? Any tracks you would like to add in any of the event, please feel free to suggest us. Yeah, here is the information the team has asked for. To mark your attendance as one of the potential winners of the privilege tickets, you need to provide your full name, your country, your email ID. At the conference group page, link has been provided already. Thank you so much, Dr. Sampurna. All right, I have made all the necessary announcements. Please let me know if I missed any of them. I already was having a great day, and I'm ending this day as even more happier as I'm having my most favorite speakers in this event, Dr. Sampurnam and Dr. Habchi. I'm happy that I finally got some time with them, even in the event itself. Yeah, you're always welcome, Dr. Habchi and Dr. Sampurnam. And thank you so much to all of our attendees. Thank you for your attention, your precious time. Please make sure you...
I appreciate that. I can't thank you enough. And by far now, thank you very much for your contribution, and have a nice day.
The contribution, it's the contribution of the attendees, and the most of the part is taken by the speakers today, as we got at least I think we got all the informations about the brain injury. You covered so many topics that I can't even I couldn't even count on my fingers. It was so much to learn from our today's event. I'm glad it ended well. And about Professor Bouallag, let's just pray she get well soon, and we meet in any of our event in future. All right, this was it. If you need any more information, you can write down your question here. With that, I would like to end the meeting, and thank you so much to both of our speakers today for your insightful presentations. Yeah. If anyone would like to come live and share your feedback, any attendee, please welcome. You can come up on your screens, and you can let us know if you are expecting any more topics, something new, some more topics, some more events on some particular topics. You can let us know about that too. We will try our best to fulfill the suggestions. And about the LinkedIn Live, we will keep going for the LinkedIn Lives from now on. So every event will be a live stream on LinkedIn. Please make sure you're connecting to all of our platforms to stay updated. Thank you so much to both of our speakers and all of our attendees. Thank you for a beautiful, informative questionnaire session with both of our speakers, and thank you for all the questions and from the attendees and taking the questions, dear speakers. And if you want the recorded presentations or the recorded meeting of today, you can simply subscribe to our YouTube channel. And yes, the LinkedIn live will be there on LinkedIn profile. Yeah. Okay, for YouTube, the link is in the chat box. Thank you so much to everyone. I would like to add a line today. You made my day. Thank you so much for being present in the meeting. And we will definitely see you again in our next event on October 7th. Yeah. Please take care of yourselves. See you again. Thank you so much. It was Ghazal Sani and Namaste from India.